Hi, this is Dr. Bhargava. In this short video, I have several interesting cases to share with you. Here is our first patient. She presented for a whole body bone scan and was recently diagnosed with breast cancer. On their contrast enhanced CT, we see that they have a left breast mass and they have left-sided axillary lymphadenopathy. There is some overlying skin thickening also seen in the left breast. When we look at their whole body bone scan in the anterior and the posterior projections, we find that there is increased soft tissue uptake in the left breast. That happens because of hyperemia when there is a tumor. And their scan shows this single or solitary focus of increased uptake involving the T11 vertebral body. And on their CT scan, we find that in that location, there is a lytic bone lesion seen here on the axial and the coronal image. And so the interesting thing about this patient is that they have solitary or single site of metastatic disease to their bones. So what do we know about that? Here is a study where the authors compared solitary versus multifocal skeletal metastatic disease in patients with breast cancer, and this is what they found. The patient with earlier stage and favorable histology tend to have solitary skeletal metastasis. The patients with solitary skeletal metastasis live longer than those with multiple metastatic bone lesions, and multivariate analysis revealed that a solitary metastatic bone lesion is an independent, favorable prognostic factor in patients with skeletal metastasis. All right, here's our next patient. We were doing a lymphoscintigraphy study in this patient with melanoma. The tumor was present in the right side of the neck and had been removed. That's how they came to know that it was a melanoma. And then we injected, as a part of lymphoscintigraphy study, 0.25 millicuries at 4 sites around the scar and started dynamic acquisition in the anterior projection, and we are able to see this background of the patient head and shoulder because we have this flood source placed on the posterior camera head behind the patient. So this is the site of injection, and then in 30 minutes of imaging we found this focus extending inferiorly from the site of injection and in the pattern of the lymphatics and contiguous with that focus. If we did not get a lateral view, we would have thought that this is the activity in the lymphatics. Now in the lateral view, it clearly shows that the focus is separate from the site of injection and it is the site of sentinel node. So we performed a SPECT CT, and here are images from the SPECT CT showing the site of injection in the right side of the neck, and this focus in a sentinel node, which is posterior to the right sternocleidoid muscle, seen in this fat, where we see this focus of uptake. And here are more images showing this tiny focus right here. That's the sentinel node, and we see increased uptake in that sentinel node on SPECT CT imaging. So, SPECT CT adds distinct lymph node basins and influences radiologic findings and surgical approach for sentinel lymph node biopsy in head and neck melanoma. Here is a summary of this paper. This is our next patient. Very interesting. The dotatate PET CT is from 2 years ago when this patient was diagnosed with a pancreatic neuroendocrine tumor in the tail of the pancreas. Let's start by taking a look at this rotating image. Here we see physiologic distribution of the tracer with focal uptake in the pituitary, uptake in the spleen more intense than the liver, excretion from the kidneys into the urinary bladder, faint physiologic bowel activity, and this focus right here is their neuroendocrine tumor. This is seen right here, a solid tumor in the tail of the pancreas showing focal intense uptake of gallium-labeled dotatate. 2 years later, they came back for an MRI, and we find that the tumor is now cystic. This is a T2 weighted image showing high T2 signal inside the tumor, which tells us that there is fluid. The tumor is cystic now. And then here is the post-contrast T1 fat-saturated image showing rim enhancement around this focus, which is now cystic. So cystic degeneration of tumors can happen, and that's the interesting part about this patient, that they had a pancreatic neuroendocrine tumor and a couple of years later it became cystic. Here is a good paper on cyst-like changes in pancreatic neuroendocrine tumors when evaluated with multi-detector CT. Thank you for watching.